Welcome to the presentation for Module 11, Nursing 150. This presentation will discuss seizures. We will review the causes of seizures, nursing care of a patient with a history of seizures, and education, patient education for a patient regarding precautions to take if they are experiencing seizures, education regarding their medication, how to take their medication, what to look for, side effects, etc. This is your book's definition of a seizure. Essentially, it's an abnormal, excessive electrical discharge of neurons within the brain. It results in different types of presentations, but it can result in loss of consciousness, motor, sensory mobility, and or behavior. And we'll talk about all the different types of seizures. We'll talk about the different causes and how to identify each type of seizure and what the causes are, etc. The important thing to understand is often a seizure is caused by another underlying pathologic condition. Sometimes a brain tumor can cause a seizure, head trauma can cause a seizure, high temperatures can cause a seizure. Oftentimes, if the underlying problem is treated, the patient is often asymptomatic after that. When a source of the seizure cannot be found, the patient will be diagnosed with epilepsy. Epilepsy is defined by the National Institute of Neurological Disorders and Stroke as 2 or more seizures experienced by a person. Epilepsy is a chronic disorder in which repeated unprovoked seizure activity occurs. It may be caused by an abnormality in the electrical neuronal activity, an imbalance in neurotransmitters, or a combination of both. The types of seizure that we will discuss are generalized seizures, partial seizures, unclassified, and secondary. I have a slide that kind of differentiates and has just kind of a scale as to how these seizures lie under the umbrella term of seizures. And we'll discuss each one of these types of seizures a little bit more specifically on that slide. It's a little easier to understand when they're kind of sectioned out and differentiated a little bit. These are some of those causes, underlying causes of seizures that I discussed at the past couple slides. These are known as the secondary causes of seizures. Secondary seizures result from an underlying brain lesion, most commonly a tumor or trauma. They may also be caused by metabolic disorders, acute alcohol withdrawal, electrolyte imbalances, such as hyperkalemia, hypoglycemia, water intoxication. They can also be caused by high fever, substance abuse, and heart disease. Seizures resulting from these problems are not considered epilepsy. Various risk factors can trigger a seizure, such as increased physical activity, emotional stress, excessive fatigue, alcohol, or caffeine consumption. So again, in summary, these are secondary causes of seizures. Epilepsy is considered a primary type of seizure or idiopathic epilepsy. It is not associated with any identifiable brain lesion or other specific cause. Genetic factors most likely play a role in the development of epilepsy. This is a slide that I spoke of that kind of helps you differentiate the different types of seizures. I think the most important thing to understand is that partial is referring to the fact that it only affects one part of the brain. Calling it a generalized seizure means that the seizure is affecting both sides of the cerebral hemispheres. The most common seizures that you'll see is generalized seizures. Absence seizures are more common in kids. The tonic-clonic seizure is that seizure where the patient initially becomes tonic, which means that they have stiffening or rigidity of the muscles. The clonic or rhythmic jerking of the extremities follows. The patient may bite his tongue or become incontinent of urine or feces. Fatigue, acute confusion, and lethargy may last up to an hour after the seizure. In some seizures, it's common for them to have automatisms, which means that the patient may have like a twitching of their face or like a picking at something during the seizure, even though they might be still have consciousness, but they still, like with an absence seizure, they kind of black out and then have these automatisms during the blackout period. It's important just to kind of review these types of seizures and know that as a healthcare provider, when we witness a seizure, we need to try to kind of establish the movement that the patient is experiencing so that we can describe it to the healthcare provider who is treating the patient so that they have an idea of what type of seizure that the patient had. In order to determine, well, is it partial? Is it only happening in one part of the brain? Or is it a generalized seizure that's occurring in the entire brain? Some seizures require more safety support from the healthcare staff, such as the tonic-clonic seizure, which means the patient is having the stiffness and the jerking motions. And then the atonic seizure means that the patient has a sudden loss of muscle tone, followed by a post-ictal phase, which is confusion. In most cases, the patient will fall, which may result in injury due to this sudden lack of muscle tone. So that's important to kind of be aware of what type of seizure that the patient generally has in order to kind of determine the safety measures that we need to put into place. Again, looking at assessment of seizures, a patient who is experiencing seizures, many questions that we have to ask is how many seizures have they had? Has this ever happened before? What type of seizure? Just like we talked about in the last slide, it's important to understand what type of seizures that they're having so perhaps we can choose proper treatment for that and determine their safety, their at risk for safety if we know what kind of seizures they're having. Presence of an aura. An aura is when someone can they experience certain feelings that they have before the seizures come on. It can be different for each patient. Sometimes it's just a smell. Sometimes it's just a feeling that they have. Sometimes it's kind of they may consist of like a deja vu feeling, perception of an offensive smell, or sudden onset of pain. It's important to try to question the patient if they have an aura. Risk factors. So do they have these risk factors? Do they have a brain tumor? Have they had a head trauma? Do they have a virus that's causing a high fever? Things like that. Is there some kind of secondary reason for this patient having seizures? Diagnostic test. Typically, if it's the first time a patient has had a seizure, we're doing a variety of tests to rule out other causes. So we'll do a CT scan usually. Maybe the patient has a brain tumor that's not been diagnosed. Does the patient have hypoglycemia? Is there some kind of metabolic disorder going on? So there's a lot of, CT scan, CBC, renal labs that we'll do to rule out other things. EEG is an electroencephalogram, and that is looking at the brain waves. Oftentimes, if we can be monitoring the brain waves during a seizure, we can determine whether it is a partial or generalized seizure. We can see what's causing it, what brings it on with an EEG. An MRI would be needed in the event that we need something more specific than a CT scan. Maybe we see something suspicious on a CT scan, then we might do an MRI. Or if it's someone who can't have a CT scan due to pregnancy or radiation issues. This is just kind of a visual of what an EEG does. It records the electrical activity of the cerebral hemispheres. Each graphic recording represents electrical impulses within the brain. For example, a cerebral tumor or infarct may have abnormally slow waveforms. EEGs are used both as a diagnostic test and to provide sustained monitoring and the indications for testing and monitoring can be found in a list in your book in chapter 41, so make sure you kind of review that. Review kind of prepping a patient for an EEG. They have to make sure that their hair is clean without any conditioners, hairs, creams, lotions, or sprays. And that's so that when we put the electrodes on there, we can get a good connection. It's sort of kind of like an EKG that we talked about, where you have to get a good connection in order to get good waveforms. Usually you have to avoid the use of sedatives or stimulants in the 12 to 24 hours preceding the EEG. Instruct the patient not too fast before the test because hypoglycemia can affect the recording. Ensure a quiet room with signage to inform visitors of EEG recording in progress. And this is a picture. You can see the difference. This is normal brain waves, and then these are when a patient is having a seizure. You can see how erratic they are. And the doctors can kind of see exactly where the disorganization may be coming from during a seizure if the patient is being monitored on an EEG. It's important for the nurse to know that a patient has a history of seizures so that we can go ahead and put in place any precautions that we might have to have handy in the event that the patient does have a seizure. It definitely depends on the type of seizure, but any kind of seizure history should warrant us getting in the room some oxygen and suction equipment that are available in the event that we would need them quickly. Airway here is, you can do like a oral airway, which is a little thing that you can place in their mouth, but that would be after the seizure. That can help you make sure that the patient is getting an open airway. IV access is important in the event that the patient does have a seizure, that we can administer emergency medications such as lorazepam to stop the seizure. Side rails up and padded, those are recommended. Sometimes patients do not agree with this, but it's important to educate your patient on the purpose of the side rails up and padded. It's a safety thing. But it is important to understand that in some patients that can be uncomfortable for them and they might feel a little isolated by doing that. So just recommend it and explain it and educate them on why side rails up and padded it can be helpful to them. Seizure management. In the event that your patient does have a seizure, you need to make sure that you observe and document what kind of seizure they're having. Look at the time. You want to time it. Your highest priority is patient safety, making sure that you are there with them. Don't try to restrain them, but try to keep them from hurting themselves. If you can at all possible, get them in a side-lying position to protect their airway. Again, don't restrain them and never force anything into their mouth. You can actually cause more harm than good. Especially if it's a tonic-clonic seizure and they have clamped down. There's no way that you're going to get anything in their mouth once they have clamped down. Drug therapy is a major component of treating patients with seizures. Anti-epileptic drugs are the types of medications typically utilized to achieve seizure control. There are several different options for anti-epileptic medications. Oftentimes the treatment of choice depends on the type of seizure and the patient and the underlying problems that they might have. Oftentimes patients may require a combination of two different types of anti-epileptic medications. It's important to understand that dosages are adjusted to achieve therapeutic blood levels without causing major side effects. So it means that a patient taking anti-epileptic medications needs to be monitored to make sure that they have therapeutic levels in their system. And this can change from time to time. As a patient grows older, as a patient develops other problems, sometimes just a maturation of the patient getting older can change the way they absorb the medication. And so their therapeutic levels might need to be monitored more closely, and the doses may need to be changed according to the therapeutic levels. Important education for these medications include making sure they take them as ordered to achieve maximum effectiveness. They need to take them without skipping doses They can build up a sensitivity to these drugs if they don't take them as directed. There are several drug-to-drug and drug-to-food interactions related to the anti-epileptic medications. Warfarin, for instance, should not be given with phenytoin, which is Dilantin. Oftentimes, grapefruit juice can interfere with the metabolisms of these medications. They can increase the blood level and cause a toxicity of the anti-epileptic medication. It's important to make sure that just because a patient has not had a seizure recently, they still need to take their medication. If they stop taking it, they could risk having an emergency situation such as status epilepticus. Some of your other drugs listed is carbamazepine, which is Tegretol. Those are usually for partial or generalized tonic-clonic seizures. That can cause a leukopenia, which means a low white count, so you might need to monitor their CBC as well as their therapeutic levels of the medication. A couple other drugs to mention is diazepam and lorazepam. They're listed on the slide here. Those are emergency medications to stop seizure activity while it's occurring. Diastat is a rectal form of diazepam. It can be given in the event that we don't have IV access to administer the lorazepam or the diazepam in the IV. These are given in the situation that a patient is having a seizure or in status epilepticus, which is a medical emergency and is prolonged seizure lasting longer than 5 minutes, or repeated seizures over the course of 30 minutes. Again, every time someone has a seizure, their brain is deprived of oxygen, so it can cause brain damage. So we want to make sure that we have medication on hand for a patient with known seizure history so that we can stop it in the event that it becomes a status epilepticus. Common causes of status epilepticus are sudden withdrawal from anti-epileptic medications, an infection, alcohol withdrawal or drug withdrawal, head trauma, cerebral edema, or metabolic disturbances. Remember, cerebral edema can happen with increased intracranial pressure in a patient with a head bleed. So think of the different reasons why a patient might have status epilepticus and be on the lookout and be able to identify interventions, precautions that we can put in place. So this is just kind of reviewing everything I said in the last slide about status epilepticus. This is prolonged seizure. And just remember, it's a medical emergency because the patient's oxygen, they're deprived of oxygen during a prolonged seizure, especially if it's a tonic-clonic seizure. Make sure you monitor the airway. The emergency medications, lorazepam and diazepam, are given in attempt to try to stop the seizure. Rectal diazepam can be given in the event that we don't have IV access. Loading dose of IV phenytoin. Usually these two are given first, and then we will give the loading dose of IV phenytoin in order to prevent another seizure from happening. Remember, phenytoin is an anti-epileptic medication. It can be given IV, so it's the drug of choice to be given post-status epilepticus. If we're able to stop the seizure with the lorazepam, then we'll give them a loading dose of diazepam in order to prevent another seizure from occurring. IV phenytoin needs to be given kind of cautiously. It can be irritating to the tissues if it's given through a peripheral IV, so you need to make sure you monitor the site and administer it slowly. So just kind of a review of the first aid for seizures. Things to do during the event that a patient has a seizure. Make sure that you, again, just review that you don't try to put anything in their mouth. It's important to look for any medical alert identification to determine whether this is a new situation in this patient or if this patient has a history of epilepsy. So just make sure you review each of the things listed here as first aid for seizures. Again, review that the drug therapy is the hallmark of treatment for a patient who has seizures. There is a great table in your book that lists each medication that could be utilized. Valproate is listed on your module outline. I know that carbamazepine is also listed, the diazepam and lorazepam. Gabapentin is also utilized in some instances for anti-epileptic medication. Typically, the big piece of education is that the patient has to take this medication in order to prevent seizures from occurring. Sometimes if there's side effects of the medication that they cannot tolerate, they're going to have to call their physician. They should not just stop taking it. They need to call and see if the physician can change it to something else that they can tolerate better. They will need to monitor the therapeutic levels of the medication, as it can change from time to time associated with their age, associated with other medical problems that they might have. And typically warfarin is a drug-to-drug interaction, especially with phenytoin. They should not be taking warfarin and phenytoin. A patient on warfarin would need to be put on a different type of anti-epileptic medication. So patient and family education associated with a seizure disorder, making sure they understand their anti-epileptic medication and all the things that they need to do to make sure that they have adequate therapeutic levels. Also discussing with them resources within the community that can help them make sure that they can afford their medication and that they have access to getting their medication. We want to make sure that we help them decrease any barriers that they might have to their treatment. And emphasizing that the AEDs must not be stopped even if the seizures have stopped. They need a balanced diet, they need proper rest and stress reduction techniques to decrease their incidence of seizures. A lot of times it's important to keep a seizure diary to determine whether there are factors that tend to be associated with seizure activity. So if it's working overtime, every time they work overtime that they have a seizure, maybe they need to kind of see if they can work with their employer and decrease the times that they're working overtime. Employment can oftentimes be an issue with these patients. They may not be allowed to work in an environment where they're operating large machinery, pilots, dangerous equipment, due to the fact that they run the risk of having a seizure during operating this equipment. Sometimes these patients are not allowed to drive until they've been seizure free and have been compliant with their treatment, usually for a good while. So it's it can be devastating to their life and to their lifestyle if they aren't able to drive and work and things like that. It can be a financial burden. So that's why educating them and making sure they have access to their treatment and they're successful in their treatment, that way they can maintain a functioning lifestyle. There are some surgical intervention options for patients who have seizure disorders. It's typically reserved for patients who cannot be managed effectively with a drug therapy. Vagal nerve stimulation can be performed for patients with generalized seizures. Scratch that. It's more for patients who have simple or complex partial seizures. It cannot be utilized for a patient who has generalized seizures, because remember, generalized seizures is where the irritation is taking place all over the brain and not in just one certain particular spot. These surgeries are rare, and like I said, they're usually only utilized for patients who cannot adequately be controlled with the PO medications. So just in review, the goal for nursing care of a patient with seizures is to help to identify reasons why a patient might be having seizures. If the reasons can be identified, we want to help in the treatment of those other issues. Perhaps it's withdrawal, perhaps it's a fever. Also, it's your role as a nurse is to, if it's someone who needs to be on anti-epileptic medication, they need to have education on how to take their medication, how to remain compliant, and how to prevent seizures from happening, helping them identify triggers for their seizures, if it's stress, if it's lack of sleep, things like that. Help them to identify that those are causing the seizures, and so they need to try to avoid those kinds of things. And then just making sure that the patient has support in the community to help them maintain their compliance with their treatment and maintain a functioning lifestyle. This concludes the presentation for Module 11 regarding seizures.